grow, but they decrease particularly from our first period onwards. And at menopause, we still have some eggs left, but they're older and they're less sensitive and less responsive to the hormones that we have, and hence our hormone deficiency. So why all the fuss if it's supposed to be a normal life stage? Unfortunately, for a lot of people, there can be severe symptoms, and this can lead to a significant impact on their own health, their relationships at home and at work, and difficulty in coping with life. And the consequences also then of extended estrogen deficiency can be very severe on some people. So what are the symptoms? Well, we're looking at irregular periods is usually the first one that starts. Flushes and sweats, psychological symptoms, sleep issues, headaches, palpitations, weight issues, and effects on our bladder and vaginal area. So let's go through some of these. So the first, as I mentioned, is the irregular periods, and anything can happen with these. You can end up with short periods, longer gaps between periods, heavier or lighter, and a lot of change. And the difficulty is that these changes are occurring at a time when other pathology can be going on in our womb or ovary. So it's very important just to make sure that it is just perimenopausal bleeding and not an underlying abnormality. We're all very much aware of the flushes and sweats. The difficulty is some people think that these can't occur until the periods have stopped, but that's not the case. They can occur long before the last period. About 75% of women are affected by menopausal symptoms. 25% get through without much difficulty. But of those that get them, 30% can be severe, and they can last anything up to 5 to 7 years. They can even reach into our 60s, and in those women, they can also be quite severe. There's a lot of variation between ethnic groups and countries, and often the actual underlying cause of the flushes and sweats can be poorly understood, but there is no doubt that smoking and a high BMI results in increased severity and increased frequency of these flushes. Psychological symptoms can be extremely debilitating. Low mood, emotional ability, anxiety, depression, inability to cope, where we could multitask before suddenly isn't possible, a lot of fatigue, lack of energy. And these symptoms also occur at a time when life is changing for us all. We may be facing retirement, kids have left home, all sorts of issues, other outside stresses that need to be taken into consideration apart from the menopausal symptoms at all. Sleep can be a huge issue. Sometimes we've no difficulty getting to sleep, but staying asleep is the problem, waking up at 3 or 4 in the morning and not being able to get back to sleep. And the sleep can be disturbed purely by the sleep pattern itself, or sometimes night sweats can wake us, or joint aches and pains can wake us. Weight gain, another big issue. Our metabolism changes in our mid-50s. We have an increase in body fat and less lean mass, and we put up an average of about 0.5 kilo per year. Very difficult, and because it's all around the middle. And again, memory and brain fog can occur and do occur in a lot of people, and it can be related to poor sleep or just generally issues on its own. The bladder symptoms also quite common, and these unfortunately can continue right through as we age. We can get frequency of urine, urgency where we can't hold on when we want to go, painful urination like burning sensation. We can leak when we cough or sneeze, or leak when we can't hold on, and we can get recurrent infections. From a vaginal point of view, we can end up with sexual difficulties. Because of dryness, because the skin thins out and the burning and the itch, we can end up with painful intercourse and loss of sex drive and sex arousal. Fertility is another issue. If we haven't managed to have gotten pregnant by our late 40s, early 50s, then there's the stress of the difficulty in the ability to conceive. Or if we're trying to avoid a pregnancy and our cycle is very irregular, then of course there's a risk of pregnancy. So contraceptive issues may need to be addressed. What about the long-term effects of estrogen deficiency, as we mentioned earlier, where 1/3 of our lives may be spent in this state? Well, for some people, you can be certainly more prone to cardiovascular disease, osteoporosis, and again, the long-term effects on the bladder and vagina. Just a word about heart disease, because it is very common. It is the biggest killer of us women as we go through menopause. Cancer is much, much less, as you can see in the orange triangle there. But if you ask women what's their greatest perception of the risk of death, all will think that it's more cancer related, particularly breast cancer, when in actual fact, 1 in 4 of us is going to die from a heart related condition. And in many cases, this can be totally preventable. Heart disease and stroke are the most common cause of death of women in Ireland. And as mentioned, 1 in 4 of us will have a stroke or a heart attack. 5,000 Irish women die each year, and most of these will have from heart disease, and most of these will have already gone through the menopause. And we're 7 times more likely to die from cardiovascular disease than we are from breast cancer. And that's a frightening thought. But it's good also insofar as these conditions can be prevented and our risks can be reduced. We think that we're protected from heart disease and that it's a male condition, but in actual fact, it's not. We get it just the same as the men, but we're about 10 years later. The difficulty is we don't do as well as the men with intervention and treatment, mainly because we have different risk issues, more likely to have blood pressure, high cholesterol, we smoke, diabetes, and overweight. And if you look at those conditions, all of those can be managed, and it's up to us to take responsibility for our health to do that. What about osteoporosis? This is what we know as brittle bone disease. Unfortunately, it is a silent disease, and often the first sign of it is a fraction. You can see from the picture here how thin the bone can get with this condition. It occurs in 1 in 3 postmenopausal women and 1 in 10 men. But it can affect all age groups, particularly younger people who have a very low BMI or who have eating disorders or excessive exercising. It has a major impact on our quality of life, as you'll see in a minute, and it is a very significant health cost, both from our own point of view and from the health services. More women die from complications of osteoporotic fracture than from ovarian, uterine, and cervical cancers combined. And the burden is huge and more than all the sites of cancer, with the exception of lung cancer for women. 50% of women and 20% of men will experience an osteoporotic related fracture in their lifetime. And in the first year after we fracture, we have a 20% chance of a further fracture within that 12 months. There are a number of risk factors. Some of them we can't change, like our age, our family history, our stature, but there are a number that we can modify and reduce our risks of osteoporosis, such as smoking, alcohol abuse, exercise, our nutrition, our low body mass, and susceptibility to falls. All of these can be modified to reduce our risks. If we look at what happens to our body with osteoporosis, in our 50s, all seems good, and the first risk is usually risk of fracture of the wrist. The vertebrae can collapse with osteoporosis, and eventually we can become bent over, and therefore there's compression on our ribs, on our stomach, and so we get stomach issues, we can get bladder issues, and of course pain and risk of hip fracture. So what can we do to manage all of this? The most important message I want all of you to take home today is that we need to have a healthy lifestyle. With this, we can ensure a healthier aging process. So a good healthy diet, plenty of exercise, 150 minutes of a brisk exercise per week, no smoking, moderate alcohol, maintaining a healthy weight, and doing our pelvic floor exercises. All of these will maintain healthy bones. It will reduce our risk fractures for cardiovascular disease. It's also important that we participate in all the cancer screening programs, and indeed wear our sunscreen and protective clothing when we're out in the sun if we get it. Unfortunately, despite our good efforts to have a healthy lifestyle, our spirit is willing, but sometimes the flesh can be weak. So what other options have we? Well, HRT is one. And the most important element of this is estrogen. This is the hormone that will reduce our symptoms and indeed protect us to some extent going forward. So estrogen can be given by tablet form or through the skin by patch, gel, or spray. The dose we start at depends on our age and symptoms. We measure the response to it by the response of our symptoms to the treatment. There is no point in doing bloods, they fluctuate so much, so it's really our response of symptoms. And the length of time we're on it varies for every single individual. As mentioned earlier, most of the symptoms will last for 5 to 7 years, and that's our usual time span, but it is not written in stone, it's very much individualized. Because we give estrogen, it can aggravate the lining of the womb, so we need progesterone to counteract that. And depending on where we are with periods, if we're still getting periods, then we need to give the progesterone in a cyclical manner for either 12 or 14 days in the month. But if our periods have stopped for more than a year, or if we're over 54, then we take progesterone continuously. We usually try and use the most natural progesterone, which is the least side effects and the least effect on clotting. And again, depending on where our periods are, your doctor will decide how much of it you need. It can be given in tablet form, through the skin, or with an intrauterine device called the Mirena. And the Mirena is the only one that's licensed as part of HRT. I mentioned testosterone because it's out there a lot on social media as working and improving lots of symptoms. The only symptom that testosterone is researched and evidenced for is loss of libido. It's not licensed for women. We don't have any for us. We have to use the male testosterone in a diluted dose. And it's very important that blood levels are checked before you start. And again, at 6 to 8 weeks later and at 6 months. And if it hasn't had an effect at 6 months, it's not going to work and we stop it. What about our vagina and bladder symptoms? Well, pelvic floor exercises are very important. We can use local estrogen cream or tablet or a pessary. And there's also vaginal moisturizers, lubricants, surgery if needed, particularly for any prolapse. And there's laser treatment, which works well for vaginal dryness. Unfortunately, with all medications, there are side effects. And these can be quite common, but will usually resolve within a couple of cycles of taking treatment. If they don't resolve, then it's a matter of just altering around maybe the way we're getting the hormones or the dosages. And the most common side effects are breast tenderness, headaches, nausea, leg cramps, fluid retention, some irregular bleeding within the first few months, and mood swings. There are also contraindications, or these are very important. There are some women who cannot take HRT and should not take HRT. And those are ones with a hormone-related cancer, or if they've had a clot in their leg or their lung related to pregnancy or the pill. So for those, there are other treatments. We have plenty of options for managing menopause. And there are a number of drugs listed here which work very well for menopausal symptoms. And deciding which one will depend on the symptoms that are being presented. Some of them, however, will react with medications that patients may be on or may affect the liver or the uterus, particularly St. John's wort and black cohosh. And we prefer to avoid these if at all possible. Again, if people are taking other drugs, it's very important that your doctor knows that so that they can decide on which one is important for you. Lifestyle treatment.
So how do you refer to us? So we see ladies from the Midwest. So we see Limerick, Clare and North Tipperary. Your healthcare professional can complete the referral and either they can post it to UHL, central referrals at UHL, or your GP will be very familiar with using HealthLink and sending the referral that way. So once you get offered your appointment, we send you out a questionnaire in the post. So it's really helpful if you can fill out this questionnaire to the best of your ability. It just really helps when you come into us to kind of know what's the most troubling symptoms that you have, and it helps to focus the consultation. So what can you expect when you come into us? Well, you'll meet one of the doctors or myself. We'll go through a very detailed history with you. We'll discuss all the options available to you. We may need to do an ultrasound. We may take bloods. It'll all depend on the day. And if you need a prescription on the day, we'll give you that. So if you're sitting there and you're thinking, I don't want HRT, and or my doctor said I can never have HRT, can I still attend? Absolutely, you can attend the clinic. It's not a HRT clinic. Yes, we do prescribe HRT, but that's only one thing that we do. So are there side effects? Yes, and Dr. Casey mentioned some of those. And if you were with us, we will go through all that with you, whatever we decide to prescribe with you on the day. And what kind of options are there to treat my symptoms? Well, that's what tonight is all about, really. There's so many different ways to treat symptoms of menopause. And we like lifestyle, diet, exercise, psychological therapies, complementary therapies, hormonal and non-hormonal medications. And that's it. Thank you for listening.
So I was thrown into an overnight menopause, a surgically induced menopause. It's what it's medically known as. And I had a diagnosis of ovarian cancer. So I had both my ovaries and my womb removed. So for 2 years, I went from diagnosis to operation to chemo to operation. And at the time, you're just getting through all of those things, even though you would hear about the menopausal symptoms and you think maybe is it or isn't it, but I didn't really come to terms with my symptoms being menopausal symptoms until everything else finished. And then I could think about it, okay, I am in the menopause. And then I said, right, okay, we need to go and do something about this now. It was, for me, the predominant symptoms were brain fog, not being able to feel like myself again, tiredness, the bloating in your stomach. But it was mainly the brain fog. Somebody standing in front of you and it's like, I can't remember her name, stuff like that. The whole sense of being overwhelmed, everything was overwhelming. And yeah, just not the mood not being great. Yeah, and then obviously there was the vaginal dryness piece, there was, the painful intercourse, all of that as well. For me, I had a cancer diagnosis, and that, I grew up in a time where you don't go near HRT. HRT is not good for you. HRT may cause cancer. And we all know that that's not true now. But I grew up in that era and I never heard of anybody taking HRT. None of my relations did. I decided, right, I have to get more information at least. So that's the route I went down first. So I talked to my gynecologist, I talked to my oncologist, and I talked to my GP, and I heard about the complex menopause clinic. And this was like manna to heaven for me, because it was somebody that understood what I went through. It was somebody that specialised in somebody with a history that I have. So I was blessed to get an appointment in the Complex Menopause Clinic in Nina. And I met Dr. Kathy Casey and I met Aisling Mulcahy, the CNS, and everything came together then. She changed around some of my medication and I have not looked back since. It's just an absolute godsend, the complex menopause clinics.
Thank you both, Aisling and Anya, and a special thank you to Anya for sharing your own personal journey and sharing the support that you received from the Complex Menopause Hub. Our next speakers now are Charlene Hyland and Michelle Maher, who are clinical specialist pelvic floor physiotherapists. And they will speak to menopause and your pelvic floor. And we might also have an opportunity to practice some pelvic floor exercises during this presentation. And immediately following this, we will have Nuala Chute, who is a service user, who will tell us about her experience of using this service.
Hi, my name is Michelle. I'm a women's health physiotherapist here in Nina Hospital, and I'm going to talk through how menopause can affect your pelvic floor. So just firstly, I want you to have a little visual of your pelvic floor structure. And what you can see in the image here is your bladder towards the front, your womb in the middle, and then your bowel towards the back. And underneath those organs, you can see a sling of pelvic floor muscle that is designed to support these areas. These are all responsive to changes in the levels of estrogen as they decline throughout the lifespan. These changes can result in the following conditions happening. So things such as your tissues becoming thinner, they can become less flexible or elastic. You can find there's less lubrication in the area. The ligaments and muscles that support the area can become less supportive with the decline in estrogen. There's also a rise in the pH levels, and this means that your vagina can become more acidic, and therefore there is a change in the balance of both your good bacteria and your bad bacteria. This is known as the genitourinary syndrome of menopause. The vaginal symptoms that can be experienced include dryness, which can result in UTIs. You can experience itching in the area. You can experience atrophy, which is a decline in the muscle bulk in the area, and then also dyspareunia, which is painful intercourse. The urological symptoms that can occur include urinary urgency, which is kind of a strong sensation that you really need to pass urine. You can become more frequent in your visits to the toilet. The actual experience of passing urine can become more painful, and you can also experience urinary incontinence, which is leakage of urine. So what can pelvic health physiotherapy do? Well, we have a team of clinical specialist physiotherapists located throughout the Midwest who can help manage these symptoms. You can be referred with any bladder or bowel dysfunction type symptoms, including leakage, prolapse, painful sex, and overactive bladder. You can have your GP or your gynecologist refer you into our service by sending a referral with your symptoms on it into a central referral hub in Limerick, and then you will be located to a physiotherapist in your area. We can provide education, lifestyle management, and advice on keeping a healthy bladder and bowel. And a large part of our treatment will focus on your pelvic floor in order to make it work correctly for yourself. I'm now going to hand you over to my colleague Charlene, who will take you through how to do your pelvic floor exercises.
Up to 74% of women will notice a significant improvement in their symptoms of leakage with pelvic floor muscle training. Let me take you through a pelvic floor exercise. Firstly, there are two types of muscle fibers in your pelvic floor, fast twitch and slow twitch. This is why there are two types of exercises that we need to perform, our slow squeezes and our fast quick squeezes. Let me take you through a slow squeeze contraction. Begin by placing one hand on your tummy and your second hand underneath your bottom around your back passage. Begin by breathing in and feel your tummy muscles rise and your pelvic floor will be relaxing. Now, as you breathe out, I want you to gently squeeze the muscle around your back passage. Imagine you're stopping wind, and at the same time, squeeze around your front passage. Imagine you're stopping the flow of urine. You should feel a squeeze and lift up. Now, breathe in and let go, and you should feel the muscle fully relax. And this is your pelvic floor slow contraction. You should aim to do this exercise up to 10 times. Begin by counting to 5 seconds, and as you get stronger and more confident, you can build this up to a 10-second hold. The important points when doing your pelvic floor exercises is that you do not hold your breath and you relax the muscle fully after each contraction. The fast, quick contractions can also be done after you've done your slow contractions. A good position to start your pelvic floor exercises is in lying or sitting, and then gradually build up to standing. It's important, if you're having any problems or are not sure if you're doing this correctly, that you get a referral to our pelvic health physiotherapist. The next presentation will be from a patient who has experienced coming to our pelvic floor clinic here in Nina Hospital.
My doctor is very good. My GP is very friendly and very informative and really wants to help. Through him I actually went to the menopause hub. He referred me to the physiotherapy service there, and I didn't know what to expect. But when I met, my physio was Michelle. She was just so lovely. The consultation assessment took an hour. I just couldn't believe she spent that much time with me. And this was like a chat with someone who really cared and was really listening. And she went through all of my symptoms, and then she asked me, could she examine me internally, which nobody has ever asked could they do before. And that was actually so good, because to get the reassurance for a professional that you're not falling apart when you're in menopause. You know, I was glad to know that things weren't going to get worse, because I think that's always at the back of our minds, are things going to get worse? So I feel a lot more confident because of that. I think it made me realise that, like Michelle said to me, basically you should be doing these Keeling's exercises all through your life as a woman. Because like going to the service, like the menopause hub, and to the physiotherapy, I think at this stage in your life, it's like having an NCT, when you're kind of an older car and you just want to make sure everything's running well.
Thank you to both Michelle and Charlene for that, and especially the practical piece and guiding us on how to do our pelvic floor exercises correctly. And also a big thank you to Nuala for sharing her story. I now wish to introduce you to Dr. Brian Kennedy, GP and menopause specialist, and Brian will inform us on what your GP can do to support you.
Hi, everybody. I hope you can hear me. So I'm Brian Kennedy, and I work with Kathy and Aisling in the Complex Clinic, and I'm a GP on the other days of the week. And so I'm going to talk today about what you can do to get the most out of your GP consultation. So this is a picture of the female genital tract. So the ovaries are represented by the boxing gloves, and the womb and the cervix are lit up in fluorescent lighting. And it's just a reminder that sometimes it is still a fight just to get basic health care if you're a woman and you need some women's health advice. So it can be hard to access it. It can be hard to get timely care. And sometimes it can be hard to get someone to listen to you. And so like women will have gone through the reproductive years dealing with contraception and, bearing the big burden of reproduction in the human life cycle. So they'll probably build up a very good relationship with their GP, etc. So they'll be used to dealing with their GP and used to dealing with periods and ovarian cysts and problems with your menstrual cycle, be it heavy periods or missing your periods or your periods being painful. So they go through all that and then they turn around and the ovaries start to fail. And it goes from being all lit up and boxing gloves to black and white. And it's as if your ovaries give you two fingers and they start failing on you. And you can get these years of perimenopause where you can feel this kind of daily kind of difficult PMT and you're cranky and you're not enjoying the kids and you're finding work difficult. And as the previous speakers were describing, losing confidence and generally losing your mojo and still having to deal with periods sometimes. And then you go to the GP and so they will often say that, oh, you're still having your periods, it could be menopausal, but you could be very perimenopausal and still having your regular cycle. So it's worth having a trial of some estrogen to try and stabilize things out for you. And just to remind that not everyone's menopause is terrible. So 20% of women cope quite well with their menopause. 20%, however, have a terrible time, and it's nearly like a really severe illness that's both physical and psychological. And they really do need help because the symptoms are so disruptive and affect them holding down, the basic day-to-day, their relationships and their work and their basic tasks, etc. So what are the challenges? So what's lovely about the Davina McCall Channel 4 documentary is that she shone a light on the menopause, and then that kind of that lit up the radio airwaves here in Ireland quite quickly afterwards with the Joe Duffy show. And for 2 or 3 days, everyone was talking about menopause. And it kind of all happened in the middle of COVID, in the middle of a very difficult time for GPs because there was all sorts of crashes with the IT systems, etc. And we couldn't link to the labs, and it was all a very difficult time. And but what we've learned from that is that there's been a huge explosion in demand and people asking for care and asking for attention around their menopause symptoms. So we should be making sure that people can access their care where they need it, when they need it, and that no one should be suffering in the shadows and secrecy, and that people should realize that if you're in the perimenopause, you can have very strong symptoms and it's not going to be reflective in the blood test. So the blood tests don't reflect it. So the GP has to believe you and has to kind of give you a trial of the hormones. And that can be a difficult one to nut out. And we need to start believing women when they tell us about their symptoms. So people have talked before about having their ovaries removed and having that awful surgical menopause where you wake up in this florid, difficult menopause. And that shouldn't be happening if the woman is able to take HRT. So we should be predicting that need. And just to point out, those young women, so under 40 is a different entity. So if your hormones are taken away 10 years before everyone else's are under 40, you're at much higher risk of those things like heart attack and stroke and osteoporosis. And we see that women don't really get heart attacks as young as men, and they live that a little bit longer. And it's because the hormones protect their arteries. So if you protect the arteries to your heart, you don't get heart attacks, and protect them to your brain, you don't get stroke. And we all know that if you fall and break your hip when you're elderly, that leads to one thing after the other and long hospital stays, and it can often end up killing older people. So we have to be mindful of that HRT can do a lot of good. And the average woman that sits in front of the average GP is going to benefit from HRT. And I'm talking about the lovely new modern HRT that we have, the gentle one that dovetails in with your natural hormones. It's a discretionary medication, so it's not like insulin. If you don't get it, if you're diabetic and you don't get your insulin, you're going to die. It's a discretionary medication, but it's a medication that can really benefit women. And it's important to match the patient to the medication and to the intervention. So what's the first port of call? So sometimes it's very unreliable sources or Instagram or TikTok. Sometimes it's the practice nurse, sometimes it's the GP, sometimes it's the gynecologist or the pharmacist or their friends, sisters, mothers. Sometimes it's in family therapy because relationships can break down. Sometimes it's from the oncology because for difficult medical reasons, maybe with breast cancer or hormone-dependent cancers, their ovaries have to be removed. It can be sometimes from a psychiatrist. So some people can get very, very depressed in midlife, and there's a peak in suicidality in women at around the age of 51, and it has to be related to the menopause and the change. So it can be a very trying, difficult time, and women can present in all different circumstances. They can present to the endocrinologist, who's the specialist in hormones. And some women could say that if you don't do something about my menopause, I'm going to end up in prison, and that's where you'll find me. So it can be very, very difficult and very, very serious. So when do women come? So everyone knows that, from the movies and soap operas, you'll see insomnia, not sleeping, the night sweats, the flashes that are disruptive. That's what people associate with the menopause. But there's all sorts of weird and wonderful things, from burning mouth and numbness in your body and all sorts of other symptoms that come. And sometimes they come with fear of missing out because they meet their friends or their sisters and they're doing so well in HRT. They want to be as well as them, and they come in looking for it. And sadly, still, because women are basically keeping the whole show on the road, they're the ones that are keeping families together and doing everything to kind of solve problems within their families and within work. They often come framing how they are failing others. So they often say, oh, I'm failing my husband. There's no sex happening anymore. Their children are noticing they're cranky and they're tetchy with the teenagers. They've got the brain fog and the poor decision making, the reduced job performance. And I found, as Siobhan said earlier, that driving on the motorway, that's actually classic. So confident drivers would think nothing of driving up to Dublin, suddenly are daunted by the motorway and don't want to go on it. And I had a woman recently who had bad dyslexia as a teenager, and she had a job where she had to write down things every day and list out things. And then all of a sudden, she just woke up unable to spell. Everything was spelled backwards, and her dyslexia just reared its head. And often you find that, like, if you were clumsy as a younger person or if you're a little bit anxious, it often comes out and worse in those perimenopausal and menopausal years. So the girls have already spoken about these the climactic scale. So this is a lovely thing you can do to your GP. And actually, you can do, and before you go into your GP, because if I did this scale on myself, not being menopausal, just on an average Wednesday after 3 days of general practice and everyone roaring and shouting at you and giving out to you, I'd nearly get upset. But what I think is very useful about it, that if you go through it, it kind of takes the emotion out of the consultation, and you kind of go in with kind of the cold fury of, I want to be moved forward. I want someone to listen to my symptoms and get on with things. And it's lovely to have documented it. So not everyone gets on with the HRT. And when someone comes in and they say, look, I'm trying HRT, and now you get the very common side effects of sore breasts and unscheduled bleeding, you can go, well, hold on a wee second now. This is what you came in with. And you can actually go through their symptoms and actually see, are we having fun here? Was life better on or off HRT? And I think it's very useful to take that time for yourself, get it on paper. And sometimes it's nearly getting the rage on the page. You kind of have it out of you then. And then when you go in to see the GP, you're ready to have a kind of clear, cogent conversation. So GPs are absolutely mithered from menopause care because there's been an explosion in people looking for care. And the problem is that intergenerationally, HRT has changed. So 30 years ago, it was put it in the water. Then 20 years ago, they studied a lot of women taking very strong HRT derived from horse's urine. Now, that HRT was a fabulous HRT. It was very strong, but it meant that women got a lot more clots, and they gave it to older women. So a lot of the studies are actually on, they're not our women. They're not the women that come to us in their 40s and early 50s. They were women that they pulled off the street in their 60s and to see how HRT would suit them. And thus and therefore, they discovered that there was more strokes and heart attacks in these older women. So we need to avoid that HRT. So modern HRT is all about these lovely bioidentical, very similar to the hormones your ovaries produce, much safer. We can deliver them through the skin. They're not associated with clotting. They don't increase the risk of heart attack and stroke, and they're much more accessible to, and they're much more safe to prescribe. So your GP, every GP is well able to prescribe HRT and has learned about HRT. And hopefully when you go see your GP, you're going to be met with someone who's trying to solve your problems, empathize with you, kind of move you forward. And they will know you from your other attendances. But sometimes they will perceive risks when starting HRT, and they might get a bit antsy if you have maybe cardiovascular disease. So if you've had heart attacks or strokes, as Ashley was saying, you should be in the complex clinic. If you have severe migraine, it can throw GPs off because it can make, it can be hormone related, so they might get a little bit antsy about it. And certainly if you have very strong family history of breast cancer, sometimes it can make it into a very complex conversation that the GPs might feel, look, is best handled by someone who's a more experienced prescriber. So if they feel there's a very high risk, they'll send you on to those complex clinics. And it's great to have them now. So we have our complex clinic running in Nina for the last 2 years about. And it's great that we're able to service that need that's there for women with complex stuff. But when you approach your GP, it's a good idea to have researched good resources. So it's not going with, well, my friend Bridie is on this and that's what I want. It's lovely if you can read the kind of evidence-based stuff. So the HSE have lovely information online. There's a great evidence-based website, the Women's Health Concern. There's loads of very accessible, readable information on that. NHS in the UK has lovely information as well. And if you get your form filled, you're taking a good chunk out of that consultation. I think some of these consultations are complex and they're long, and it's worth maybe warning the GP before you go that you want to have a menopause consultation, because the first one is often very long, and in my experience, it's at least 40 minutes. And if you know the patient, even it often is 40 minutes or longer. So you should warn the receptionist, say that you want to talk about your menopause, and usually they'd have the sense to double book you for 2 appointments. Or maybe they mightn't be able to get to it all in one appointment, but they will do their best. And if there are some GPs who aren't that confident about menopause care, you might get directed to the GP that's most confident with it. There are brilliant practice nurses out there that are excellent at menopause care as well, and they're going to all the conferences as well. So don't underestimate your practice nurse. Of course, if you have a medical card and you only have one doctor and your doctor isn't very confident with it or gets worried about it, you're going to have less choice. But a lovely option that we have locally is the Limerick Family Planning Clinic, and medical card patients can access that free of charge, I'm almost sure. So I looked at the website today and there isn't a charge, but they would have limited slots and you'd have to warn them as well. Of course, if you're a private patient, there's probably a lot more options with GPs who have special interest and do private consultations, or of course, there's a few menopause specialists locally. If you go into GP all guns blazing, and sometimes women can come in all guns blazing and they can say, I want this HRT and I want it in the gel and I want this, and they know what they want and they're very clear. That can be very helpful in one way. But I suppose if I went into my friend who's a teacher and told them how to teach 5th class or whatever, I know what I'd be met with. So it's more about kind of a collaborative approach and setting out your needs and advocating for yourself. But all the guidelines will come back to respectful, individualized care for the woman in front of you, using the modern HRT that we prescribe, and sticking to more kind of products that are through the skin. So it's the oral estrogen that we worry a little bit more about with side effects. And we like to stick to the very friendly micronized progesterone that Kathy was talking about earlier on. Okay. So for lots of women, this is a very positive consultation.
Thank you, Brian.
Oh, I'd like to go.
I'm sorry. We've had to cut you there. Yeah, I'm very, very sorry. But
12 minutes and a half. I was doing well.
You were doing well. Thank you. It's yeah, we've a tight schedule. But thank you very much. You've given us a lot of food for thought there, Brian, and a lot of, I suppose, encouragement to take control of our own menopause and come well prepared to our GP for support. Thank you. We now have another one of our community contributor videos that we're going to share with you.
Well, we would have conversation in work, like amongst ourselves, say those of us that would have gone through it or been going through it. Like, it's not something that would be talked about at home. It's just like when we're in work, we'd feel confident in talking about, just what we're going through ourselves.
The best support I had was I have a very good friend at work and much of the same age. And I think the emotional support from somebody like that is absolutely huge if you have somebody that you can actually speak to. and secondly, my GP. So I think the day I went to her and I thankfully had the courage to say to her, she just gave me as much time as possible. She was absolutely amazing. And I think the support of a good GP is, and a friend, I think to have a friend is hugely as well, huge as well.
It can be alternative treatments, it can be cognitive behavioural therapy, it can be doing your yoga, it can be doing your exercise, going out for a walk, meeting your friends.
My GP was actually a very good sport, he was, yeah, because I felt he had a lot of knowledge about, you know, menopause and women, and, you know, he was involved in different things with menopause as well, I suppose, so it was actually great to get that help.
Thank you to our contributors there. I think what they share, there's something that we can all identify with in terms of their supports. Our next expert speaker is Dr. Emer Farrell, who's a senior clinical psychologist with the HSE Midwest, and Emer will talk to us about menopause and your mental well-being.
Great, thanks for that. So I'm just going to talk a little bit about how we can mind ourselves from a psychological perspective through the menopause transition. I suppose, as a few speakers have referred to earlier, and some of the women who contributed in the videos, that the menopause transition time can be a perfect storm for us as women, because it's often a time when we are juggling multiple responsibilities, often caring for elderly parents, we might be parenting teenagers or having that life transition, children leaving home. Often we're taking on more leadership roles or increased responsibility at work. There might be issues in our relationships. It's often a time couples separate or have marital difficulties, and we might be learning to deal with being single again. And also our extended family may have health issues. We might have our own health issues. There might be financial stresses. So it can be a challenging time, on top of the fact that we're going through all those hormonal changes. So I'm just going to talk a little bit about managing hot flushes using CBT. Dr. Casey mentioned that CBT is one of the non-pharmacological approaches that has a lot of evidence. So it's just in terms of what is a hot flush. It can feel like a sensation of intense heat or sweating or palpitations or shivering, or that temperature fluctuation. So going from feeling very hot to feeling very cold. And that, you know, can be very distressing for people. So I suppose we know that women tell us that it can cause embarrassment and discomfort. It also can disrupt sleep, and it can set up a cycle where we're feeling very anxious about what happens if we have hot flush. So, like Dr. Casey and a few other speakers have said, it's the estrogen level fluctuation that causes them. And when our estrogen levels start to fluctuate, it impacts on our body's ability to control temperature. So our bodies become temporarily very sensitive to small fluctuations in body temperatures. And we know about 75% of women can have them, and about 30% have a lot of them. So the other thing to bear in mind is that if we're under stress, our threshold for hot flushes narrows. So learning to manage our stress is really important, because the more stressed we are, the more likely we're going to have hot flushes. So I think it's really important to say it's not your fault and you didn't do anything wrong if you're experiencing any of the symptoms we've been discussing tonight, but there are things that you can do about it. And I suppose just in terms of thinking about what happens with the hot flush, it starts with our physical symptoms, like this diagram shows. We might have hot flushes, we might have palpitations, and then we might have the thoughts that come with that, like everyone is looking at me, I can't cope, this is embarrassing. And then when we have those thoughts, the feelings that go with that, like I've said, is like being anxious or worried about it, feeling embarrassed or feeling out of control. And then when we have those feelings, we're more likely to engage in avoidance behaviors, like leaving the situation, leaving the room, you know, not taking up offers to socialize or do presentations at work. So I think what's really important to remember in all this is what you say to yourself about your symptoms and your emotional reactions really matter. So I'm just going to talk a little bit about that now. So what we know is that understandably, we can have thoughts like, oh no, here we go again, I can't cope, when we have a hot flush. And if we can just try and think, notice how we're thinking about our hot flushes and say things like, let's deal with this one flush at a time. These symptoms are uncomfortable, but I can manage them. Another common, thought that we can have that it causes us distress is the idea that, oh, everyone is looking at me. And I suppose it's important to remember that, I'm definitely noticing if it's happening way more than anyone else. And they may not even notice. And even if they do, they're very unlikely to be judging you. Another common thought that people can have is that I'm out of control. And I suppose we need to remember there are things I can do to take back some control, like the clothes that we wear, wearing lighter clothes, wearing layers, opening the window. Some people find things like spicy food or too much alcohol can impact on their threshold for hot flushes. And then we can get into very negative thinking, understandably, like these flushes will go on forever. I'll never get over this. And it's important, if we can't, accept that the hot flush will pass and they will gradually reduce over time. And there's a technique called paced breathing. I'm just going to do a little bit at the end about that can help us to manage the hot flush in the moment. Okay, for some reason I'm having problems sharing the next slide.
What we can do, Emer, if you have many slides left, we can take over the share, or if you wish, you can go to that lovely section you said you're going to do with everyone.
Yeah, sure. Maybe I can do that.
That would be
think we're
brilliant,
running
Emer.
behind time anyway, are we?
Yes, yes, we would love to be able to have that facilitated. So it would be great if you could come on and do that.
Okay, sure. So I'm going to take us through an exercise now called paced breathing. And so I just want you to, if you can, we've been sitting and listening for a while now. If you can maybe sit back and make yourself comfortable, and sit with your feet flat on the floor and with your chest open. And let's gently bring our focus of attention to slowing down the breath. See if you can keep your chest and shoulders still. If you like, you can try putting one hand on your chest and one hand on your stomach to help you get used to this way of breathing. As we begin to take slower and deeper breaths, see if the hand on your chest can stay still, and allow the hand on your stomach to gently rise and fall in line with your breaths. Take a few slow, gentle breaths. Allowing yourself to breathe down, slowing down the breath even further. And see if you can gently bring a soothing rhythm to your breath, a rhythm that feels comfortable for your body. Notice the sensations that are present as you breathe in and out. And when your attention becomes distracted, bring it back to the focus on your breath in a kind and gentle way. After a few more breaths, let's begin to see what it feels like to imagine that as you breathe out, feel your body slowing down a little. Or maybe as you breathe out, just notice that you're resting on a chair and your feet are on the floor. breathing down deep into your belly. Let's see if we can continue breathing like this for a few more moments. Bringing our attention to the sense of slowing down the body, slowing down the mind. Mindfully notice when your awareness is distracted from your breath. And gently bringing your attention back to rest in the flow of your soothing breath. So now slowly and gently, let's allow this practice to come to a close. Remembering at any time, in any situation, we can slow down our breath, which helps us feel calmer and more at ease. And it's just worth noticing that that takes practice, that it may not work immediately, particularly if we're in a highly stressed situation, but the breath is a tool that we have with us anytime, and just slowing down the breath, even for a minute or two, does change our physiology and calm our nervous system. And people who did take part in the CBT program for coping with hot flushes found that this breathing technique was one of the most helpful ones that they learned because it was portable and people could bring it with them. Okay, thank you.
And again, like I said, I suppose if you grew up hearing that conversation, then you'd feel comfortable, talking about it, like.
And it's not a silent thing anymore that people are saying, but it's something, it's real. And everybody, in their mid-40s, 50s, whatever, they're going through this. And it's hard to deal with it, I think. Not everyone, everyone's journey is different.
I haven't really heard, I wouldn't be at the age to experience menopause myself. But at the same time, it's handy to know for a future, for younger people to know what to expect and to be able to deal with it when the time comes for myself and people the same age group as me.
But it's giving people ideas too, if you're never going through something like that. You're sitting down and listening to people what they're going through and what we will expect to go through ourselves, when it does happen, So that's good, to talk about it. But some people don't talk about it because it is a personal thing. So it's good women to talk about it.
I would like them to know that firstly that they are enough, that you are enough, and that the value you have in yourself is very much underrated.
Thank you to Emer. It was really wonderful to practice paced breathing and experience the benefits of that even in the middle of a webinar. Our final group of speakers are from our health and wellbeing team. They are Sinead Killeen, Health Promotion and Improvement Officer, who will talk about the importance of being physically active. We have Christine Gurness, Senior Community Dietitian, who will talk about the importance of healthy eating. Gina O'Brien, who is a counsellor with our integrated alcohol service, will outline the importance of paying attention to our alcohol intake. Rachel Meskel, Senior Health Promotion and Improvement Officer, will talk about our Stop Smoking services. And then our last speaker is myself, and I will be encouraging us all to mind our sexual well-being during this time.
We've heard tonight that being physically active helps during the menopause journey, and our speakers have discussed some of the health conditions that we are at greater risk of in perimenopause and menopause. So why be physically active? The research shows that being physically active has a positive effect on our mental well-being, helps us maintain a healthy weight, protects our bones, and reduces our risk of developing disease of the heart. Being physically active can take many different forms. It might be an exercise class in your local gym, morning jog, or 10-minute walk at lunchtime. The changes to our body as we get older and during menopause means we need to do different types of physical activity. There's all different types of physical activity. Aerobic exercise like walking and jogging involves loading the bones and helps reduce our risk of developing osteoporosis. While cycling and swimming are examples of non-weight bearing aerobic exercise. The other types of exercises are strengthening exercises, where we contract our muscles against some form of resistance. This resistance might be your own body weight, a dumbbell or gravity. These type of exercises help us to maintain muscle mass. Balance and flexibility exercises also have an important role to play. They help reduce our risk of falls and keep the motion that's in our joints. Balance exercises are particularly important if our other systems like our vision and our hearing, which help us with our balance, aren't working as well. The Every Move Counts guideline sets out how much and how often we need to do the different types of exercise to help our physical and mental health. While more is better again, it is important to remember there's no smallest amount of physical activity that we need to do to get health benefits. Even aiming for 10 minutes at a time is of use. We also need to look at breaking up the time we spend sitting over the day with some movement, as we now understand better how sitting for too long can be harmful to our health. The HSE Health and Wellbeing YouTube channel have free online exercise videos suitable for beginners and designed by qualified exercise professionals. If you go into your internet search engine and type HSE exercise videos, it will bring you to where all these videos are. There's chair yoga, Pilates, strength and conditioning. Joining a group can also support us when starting to change our physical activity levels. The local sports partnerships in Limerick, Clare and Tipperary provide a variety of group exercise programs in different locations. To check out what might be running in your area, simply phone your local sports partnership or check out the Sport Ireland website to find your nearest partnership. So remember, whatever you choose to do, pick something in an environment that motivates you, that you enjoy doing, that fits in with your day-to-day routine. That way you give yourself the best chance to sticking with it and getting all the benefits we know that being physically active brings.
Hi, my name's Christine Gurnett. I'm a community dietitian in health promotion. I did a video previously of menopause. In that video, I discussed many symptoms and two major health risks that menopause can increase, and that's osteoporosis and cardiac disease. I talked about how a healthy diet, especially a Mediterranean-style one, can help reduce these risks and some of the menopause symptoms. Here's a link to that previous video. Along with other factors, menopause is often blamed for weight gain, but weight gain is actually much more of an aging factor. Around the same age when women are entering menopause, there are aging factors emerging like slowing metabolism, loss of muscle mass, and decreasing physical activity. Both men and women commonly gain a kilo or two a year at this time of life. The biggest difference for women is that menopause changes our shape. The changing levels in our hormones cause us to store our weight around the middle rather than spreading it around. That's why we really notice it. But muscle burns more calories than fat, and even if our weight stays around the same as it was before, then we may notice our waists are getting a bit bigger. The important thing, though, to remember is that although weight gain is common around the time of menopause, it doesn't have to be inevitable. Weight gain is determined by many factors. Genes play a big role, but there are many other factors too. For instance, making sure you stay active and maintain your muscle is important, as when we lose muscle, we replace it with fat. Stay as active as you can, and I think Sinead's referred to some of our videos on the HSE website. They're excellent, short, simple strength training and conditioning videos, and you can follow these at home without joining a gym or buying special equipment or clothing. Your sleep pattern is very important. There's lots of evidence linking disrupted sleep or lack of sleep with weight gain. We should practice good sleep hygiene. Stress is another factor. When we're stressed, we tend to comfort eat, and we eat more high-calorie snacks, or maybe we skip meals and binge. Try some mindfulness or yoga, or maybe some stress reduction techniques to manage your stress. Then, watch out for the caffeine. Caffeine is very disruptive to our sleep pattern, and it's active in your body for up to 8 hours. It's helpful to cut down on caffeine after 2 or 3 o'clock in the afternoon. Eating lots of fruit and vegetables in your food plan is very important. The majority of people in Ireland don't get enough, or the 5 to 7 that's recommended. The easy way to encourage this is to make sure that at least half of your plate at every meal is fruits or vegetables. The Mediterranean diet has healthy benefits for us too, so add some oily fish and some nuts and seeds into your daily plan. Despite what current fads tell us, don't forget about our carbs for your energy, for fibre, and for weight management. Aging can cause our GI system to slow and we suffer from constipation. We need plenty of fibre and water to get things moving and stay regular. Fibre helps us to feel full and satisfied, and there's lots of evidence that complex carbs or whole grains help us in keeping a healthy weight. Carbs are our body's best energy foods. Without carbs, we find energy elsewhere and we take it from our muscle stores. Complex carbs are important for this and for B vitamins and gut bacteria. So add those whole grains to your daily food plan. Beware of those fad diets. There are many times they come around in different guises every couple of years. If they worked, we wouldn't need to keep reinventing them. Remember, however popular new diets are, the healthy eating guidelines have been around for 60 years or more. Those messages are: follow the food guide pyramid and guidelines for variety, moderation, and balance. Eat your 3 regular meals a day, plan them ahead, eat slowly, enjoy, and feel satisfied but not stuffed. Choose lower fat, sugar, and salt options for meals, snacks, and for drinks. Keep an eye on your portion sizes and calories. Start small, as you can always have seconds. Make healthy snacks something that you take with you to work, or if you're out and about. Fruit works well. And then don't forget to move more. Currently, menopause supplements and miracle diets are big money makers. But there's no amount of supplement that will make up for an unhealthy diet. Here's a link to our Irish food guide pyramid. This will help you to plan a healthy eating pattern, and there's lots of evidence behind it. One thing to remember to maintain our health as we age is to make healthy eating a priority. Usually, as we are aging, we may not burn enough calories like we used to. When making changes, it's important to make small changes so that we can stick to them in the long term. However, we're only human and not perfect, so we need to work on accepting our ever-changing bodies. Most importantly, remember to embrace the newer, wiser, stronger you and enjoy your second spring.
Hi, my name is Gina O'Brien. I'm a counsellor working in the Midwest Integrated Alcohol Service. The World Health Organization says that there is no healthy or safe amount of alcohol, but the HSE current low-risk guidelines for women say that women should consume no more than 11 standard units per week. One standard unit is considered a half pint of beer, stout or ale, a single measure of spirits, or one small glass of wine. During menopause, alcohol can worsen the physical and mental symptoms. Women are at increased risk of osteoporosis, heart disease, cancer, anxiety and depression. There are a number of tips and techniques that can help you reduce your alcohol use. Keeping an alcohol diary. Note how much you drink, when and why. Choose alcohol-free days. Don't bulk buy alcohol or keep it in the house. Switch to 0% drinks. Switch to a lower alcohol drink, for example, switching wine to beer. Join a group or volunteer. Get active. Get a partner or friend on board to help keep you accountable. We'll post some links to self-help tools and resources at the end. But remember, if you feel you need professional support, just reach out, as support is always available.
Hi, I'm Rachel, and I want to talk to you about stopping smoking, because stopping smoking at any time of life is really important for better health and to live longer. Menopause is an ideal time to stop smoking. By not smoking, you delay the onset of menopause and you reduce the number of hot flushes. Also, more good news, you can decrease the risk of developing osteoporosis and gum disease. The interplay between smoking and bone health is very complex. If you smoke, the risk of bone fracture is increased by 25%. So really good news. There is an entire team of us here at Quit Midwest ready to help you. You can ring us, you can talk to us, and we can support you as you want to stop smoking. So contact us at Quit Midwest. Oh, and just to make sure that we get the point across, they gave me a really, really big sign to hold up. You won't be able to miss this.
Sexual Health, Menopause and Me. Hello, my name is Mairead Kelly and I'm a Health Promotion and Improvement Officer with the HSE Midwest, and I have a remit around sexual health promotion. I am based in Limerick. We are all sexual beings, and as we embark on the next phase of our lives as perimenopausal or menopausal women, that doesn't change. What can change for some of us is how we experience ourselves as sexual beings. In the years around menopause, we as women may experience some changes in our sex lives. For some, it is more enjoyable as the fear of unwanted pregnancy abates. For others, they find that they think about sex less often or they don't enjoy it as much. Reducing hormone levels during this time may cause vaginal tissues to become thinner or drier, which may make penetrative sex uncomfortable or painful. There are treatments available to help your symptoms. For example, the use of lubricants greatly enhances the experience of sex. There are a wide variety available over the counter in any pharmacy. Just be mindful, if you are using condoms during sex, that not all lubricants are safe to use with condoms, as some reduce their effectiveness. Being less interested in sex as you get older is not a medical condition that requires treatment. Libido naturally goes up and down during one's life course. However, if changes in your sexual health bother you, I recommend that you talk to your GP or practice nurse or other supports that may be available in your area about possible ways to help. Sexual pleasure is a much neglected yet fundamental part of sexual health. Research indicates that sexual pleasure contributes to the quality of life and the quality of intimate relationships, both of which support individual and societal well-being. There are many ways to achieve sexual pleasure. Penetrative sex isn't the only way. Touching, stroking, massaging, kissing are some of the many ways in which sexual pleasure can be shared. The key message is to be kind to yourself, to know what's right for you and to enjoy it. I invite you all to own your own sexual pleasure destiny and be creative in how you want to be pleasured and give pleasure in a safe, consensual way. Thank you to all our health and wellbeing contributors for inviting us to look at our own lifestyle behaviours and how by making small changes, we can improve our overall health and well-being during perimenopause and menopause. Our closing video this evening is Anya Collins, who really sums up this part of our lives very well.
Let's face it, every woman is going to go through menopause. And it's up to every woman to equip themselves with the knowledge that I am going to go through this. It's the acceptance piece. And to know that there is so much out there, so many specialist people who are specially trained in this area to help you with your symptoms. Every woman has different symptoms. No, there is no one size fits all. And there is someone there to listen to. There is help available. It's not to fear it. It's not to be feared anymore. And it's to know what to take with specialist advice and live your best life, basically.
We have reached our question and answer stage of the evening. So I would like to invite and welcome our panelists who will be joining us for this. So we will have Dr. Kathy Casey, consultant obstetrician and gynecologist. We have Dr. Brian Kennedy, GP and menopause specialist. Aisling Mulcahy, clinical nurse specialist with the Complex Menopause Clinic. Michelle Maher, who clinical specialist pelvic floor physiotherapist, and Dr. Emer Farrell, senior clinical psychologist with us here in the HSE. Can I also draw your attention to our closing poll at the end of the webinar? Can I invite you all please to complete, as your answers will inform our further programmes of work around menopause in the Midwest. We have had a very successful evening. This evening, we've had over 1,000 people attending and submitting questions. So thank you to everyone. But because of the number of questions, we will not be able to answer all of them. So we will be just pulling a selection of them for our panelists to answer. So if it's okay, we will begin, and I will pose our first question to you, Dr. Casey, if that's okay. And the question is, I find myself very cold with the menopause. Is this common?
It can happen, absolutely. Most of the women will complain of heat, but then there's the shivering and cold aspect to it also. So yes, it can happen, and it is one of the menopausal symptoms.
Okay, thank you. Brian, I have a question here for you. I still have my periods. My GP says I can't be menopausal. I feel I am. What can I do?
So that's simply not true. You can have your periods and be menopausal. So you can have your period every month and have hot sweats and flashes. And there is no blood test to prove that. So that involves the clinician kind of believing your symptoms and maybe giving you a trial of estrogen to stabilize out your estrogen so that you never fall below a certain level and see if that improves. Just to add to Kathy's answer there,
Yes.
I'd say that's the equivalent. Like if that woman went into the average menopause clinic and she was cold all the time, it'd be like sitting in a clinic with your perfect baby that never cries beside a colicky woman. I think they'd all be very jealous. But the vast majority of women would have a lot of flashes and hot. So cold is interesting, but I'd wonder, should she check her thyroid as well, you know?
Okay, thank you. I'm going to go to you, Michelle, with our next question, if that's okay. What the possible causes of pelvic pain in a 45-year-old woman who has had an internal and external ultrasound with normal results?
Okay, well, I suppose firstly, I would probably need to know a little bit more about this particular lady's symptoms to give her a concrete answer there. It's great that she has had her internal ultrasound scan done. So I suppose from a physio point of view, potentially it could be down to the declining levels of estrogen causing vaginal dryness, perhaps painful intercourse, perhaps down to the thinning of her tissues. I suppose really what I would recommend there is her having a referral to a pelvic health physiotherapist to do an in-depth exam where we would go through her symptoms in detail and perform a physical assessment with her. Outside of that, obviously suggesting that her GP has ruled out all other possible causes.
Okay, okay, thank you. Does anybody else want to add anything to that, or? No, okay. Aisling, just a question for you. I am wondering if there's a possible link between migraine and menopause, particularly if you got periods if you got headaches, sorry, at the time of periods.
I might actually give that one to Dr. Casey or Dr. Kennedy.
Okay, okay.
I'm happy to take that. Yeah. I think when you have menstrual migraine, in other words, period migraine that occurs coming up to a period or during a period, that usually settles down and stops once the periods stop. So once they go into menopause, the migraine can ease. But you can get women who are still getting migraine through menopause. And in that situation, then they can take HRT, but it needs to be monitored closely. And there are certain associations with migraine, like if they're getting aura, we have to be very careful. But if their symptoms are severe enough that it's interfering with their quality of life and other options may not be available to them, then it's something that we would treat, but it does need to be monitored closely. But the typical menstrual migraine will settle at the time of menopause.
Okay, okay, thank you. Emer, for you, a question came in. How would you know the difference between severe anxiety and menopausal symptoms?
Oh, it's a great question, isn't it? Yeah, I mean, I guess it depends on, is it sudden onset or is it something someone's been struggling with for a few years or that they previously had episodes of anxiety. But it is part of the menopause symptoms. So I guess it's definitely worth talking to the GP, maybe thinking about some of the HRT options to see does that reduce it, as well as using things like the pace breathing, and some of the CBT techniques around dealing with catastrophizing, or just, keeping a diary of what your anxious thoughts are and what you might say to a friend. But this is the thing. I think it's hard to differentiate what's the underlying cause, whether it's, an underlying anxiety disorder or whether actually it's to do with the menopause symptoms.
Okay. I think what's coming through very strongly here is the need for us all as individuals to contact our GP first as the first point, and then allow that then to refer us into other services. That would be. Aisling, this one is in relation to the complex menopause clinic, and what is the waiting list like?
Yeah, so with the waiting list, when we get the letters, we have to vet them, and we vet them as either urgent, semi-urgent, or non-urgent. And at the moment, the non-urgent, you're looking at around 6 months.
Okay, okay. We've one final question. Time is, and that is, and I'll just put it open to all of you. If you are managing menopause fine, should you take HRT to reduce your risk of other diseases? For example, heart disease, cancer, osteoporosis.
Do you want me to go first on that, since I'm...
Yeah, that'd be great. Thank you.
I think the most important thing is that we're all, from the guidelines and from the recommendations from the various colleges, that HRT is indicated for symptoms, and it is used to treat symptoms. There is no doubt that it has the beneficial effect on other conditions, but lifestyle, diet and exercise are very important, and they would be the first line. But if somebody has, mild symptoms and there is an issue that where they are at risk of developing osteoporosis or heart disease, then yes, HRT can be used. And it is a gold standard treatment for osteoporosis in the peri and early menopausal women. But as they get older, they move on to other treatments. But I would stress that lifestyle, diet and exercise, really important to reduce a woman's risk of disease going forward.
Okay, thank you.
And I would maybe add to that the rules are different if you're under 40. So if you're under 40 and you're very young, we'd be very pushy with the HRT. And if you've kind of an early menopause, you're 40 to 45, we'd still be encouraging if we can find an excuse to give it to you. And over 45 generally becomes a discretionary medication that's not absolutely necessary. But it's often worth maybe doing something like maybe getting a DEXA scan. So women might find, if my bones are thin, that might push them into maybe thinking, I'll go HRT. But I think one of the big things around that is the age, I think, at menopause. Yeah.
I think it's vital. You're right, Brian. I think premature ovarian insufficiency is a separate condition altogether to what we're talking about tonight. There is no doubt that if a woman is without estrogen and she's under 40, or indeed some of them in the early 40s, they are significantly more at risk of long-term illness, and they should be on a HRT until they would reach the normal age of menopause at the age of 50 or 51. They're a completely separate entity to what we are dealing with tonight.
Yeah. Okay. And also to just colour that 20% of women actually don't mind the menopause, and sometimes they're very relieved by it because their hormones can be very difficult to deal with. And so it's not always something that needs interference or medical intervention, you know?
Okay, thank you. And sorry, this is definitely the final question, and it's in relation to HRT and the talk about HRT. When is the free HRT becoming available, or do you have any update on that for all of us here?
So at the moment, we still have no update on that. We're all looking forward to January, to the free HRT. As we know, that hasn't happened. Now, I have reached out to our local TD here in Nina, and they were speaking to the Minister of Health to see what's happening. So we're in the dark. I think we're all in the dark. I think just keep the pressure on. We were promised this, so we just need to keep the momentum going for us women of Ireland and the Midwest.
Okay, so wait and hope. That's
and a bit of pressure.
And a bit of pressure. Okay.
Yeah.
Okay, thank you very, very much to all of you. We have now come to the end of our webinar, to our evening. I'd like firstly to thank all our speakers, our panelists and contributors for giving their time, their expertise and for sharing their experience. Secondly, I wish to thank the following for making this webinar happen: the working group who worked tirelessly to make this a reality over the past few months, to thank the HSE Midwest, the Complex Menopause Clinic, to thank our Head of Service here in Health and Wellbeing, Niamh Wallace, to thank our broader Health and Wellbeing team, our bridge interpreters and IMS. But finally, I want to thank you, our audience, for joining us here this evening. We had over 1,000 viewers here this evening, and I really hope that there was something here for all of you. So have a lovely evening and take care. Bye.